meeting adequate nutritional needs is a major problem. Worldwide, with the African nations and India having the highest rates of death due to hunger. We in the United States tend to be undernourished due to poor food choices, but not due to accessibility. While approximately a third of the United States residents appear to be well-nourished with an elevated body mass index, being overweight is a form of malnourishment. Unfortunately, those in developed nations have an abundance of access to high-calorie, poor nutritional quality foods, for example, fast foods. Poor food choices combined with advanced technology which decreased the need for physical movement lends itself to weight gain. Basic nutrition. Daily energy comes from 3 macronutrients: proteins, carbohydrates, and fats. Food energy is used to maintain temperature, respiration, cardiac output, muscle function, and protein synthesis. Nurses are at the forefront of determining patients' nutritional status and providing proper nutrients when patients are unable to provide for themselves. Every 5 years, the U.S. Department of Health and Human Services, DHHS, and the U.S. Department of Agriculture, the USDA, update the nutritional guidelines. Here is a list of the guidelines from 2005. This is all equals basic common sense when it comes to daily nutrition and activity. Consume a variety of nutrient-dense foods and beverages within and among the basic food groups, while choosing foods that limit the intake of saturated and trans fats, cholesterol, added sugars, salt, and alcohol. To maintain your body weight in a healthy range, balance the calories from foods and beverages with the calories expended. Engage in regular physical activity and reduce sedentary activities to promote health, psychological well-being, and a healthy body weight. Consume a sufficient amount of fruits and vegetables. Choose a variety each day. Consume 3 or more ounce equivalents of whole grain products per day. Consume 3 cups per day of fat-free milk or low-fat milk or equivalent milk products. Those who drink alcohol may have to drink up to 1 drink per day for women and at most 2 drinks per day for men. Now, the source for this is the U.S. Department of Health and Human Services, DHHS, and the USDA, the Department of Agriculture. And that's from 2005. The USDA developed the Food Guide Pyramid back in 1992 to emphasize the principles of variety, moderation, and proportion. Since the original inception, several variations have been created, such as a pyramid for vegetarians, the elderly, those on the Atkins diet, and those from various cultural groups. The pyramid has now been modified to show plates, and the website is now called myplate.gov. You can go on this site and fill out fields with your height, weight, activity level, and it will show you a plate of what you should be eating. The Joint Commission says that all patients should be assessed for nutritional status within 24 hours of admission. Some patients who seem particularly out of range of the normal BMI should receive a more in-depth assessment and be referred to a dietitian. When patients are in the hospital more than a week, nutritional assessment should be part of the daily plan of care. Unfortunately, this standard is not being consistently met in most hospitals. Assessment should include weight loss or gain history, current height and weight, and the ability and desire to eat. An unintentional weight loss of 10% over a 6-month period or 5% in a month significantly affects the nutritional status and should be evaluated. You can assess for the percentage of weight loss or gained through the following formula. The weight change is equal to the usual weight less the current weight, divided by the usual weight and multiplied by 100. So the body mass index, the BMI, is a measure of nutritional status. Normal BMI is between 18.5 and 24.9. BMI values outside of this range put patients at risk for developing a variety of complications such as infection, heart failure, diabetes, and poor healing tissue. To derive the BMI, you take the weight in pounds or in kilograms, and the height in inches or in meters, and if it's in BMI for, let's do that again. Determining the BMI in English measures, the weight in pounds divided by the height in inches and multiplied, height in inches squared and multiplied by 703. The standard metric version is BMI is equal to the weight in kilograms, height in meters squared, and that's it. So body weight and BMI usually increase throughout adulthood until about 60 years of age. As people get older, they become less hungry. That's the anorexia of aging. Ideally, older adults should have a higher BMI between 23 and 27 because it can protect from osteoporosis and because they tend to have more adipose tissue. Malnutrition occurs when protein and or calorie intake is inadequate to meet the energy needs. Marasmus occurs when calorie intake is insufficient. It's rare in the United States. And fat and protein that make up the tissue are used for energy. Serum proteins are often preserved. Kwashiorkor is a lack of protein quantity and quality in the presence of adequate calories. Body weight is more normal, and serum proteins are low. Hence, proteins might have third spacing, ascites, etc. Marasmic kwashiorkor is a combined protein and energy malnutrition. This problem often presents clinically when metabolic stress is imposed on a chronically starved patient, such as a starving child in a developing country who gets an infection. Complications of malnutrition include muscle wasting, lethargy, intolerance to cold, edema, dry, flaking skin, and various types of dermatitis, poor wound healing, infection, particularly post-op infections and sepsis. Risk factors for malnutrition include poor fitting or no dentures, poor dental health, poor eyesight, dry mouth, limited income, lack of transportation, inability to prepare meals because of functional decline or fatigue, loneliness and or depression, chronic constipation, prescription and over-the-counter drugs including herbs, vitamins, and minerals, shortness of breath, and acute or chronic pain. Visceral proteins are proteins circulating through the bloodstream that are looked at to determine a patient's nutritional status. These proteins include serum albumin, thyroxine binding, prealbumin, and transferrin. Serum albumin might not be the most accurate indicator of protein status because it's a reflection of how the patient was for a few weeks ago, and it's influenced by hydration status. The normal value is between 3.5 to 5 grams per deciliter. Thyroxine binding prealbumin, PAB, provides a more sensitive indicator of protein deficiency because it rises and falls more immediately. Serum transferrin is an iron transport protein and is used to measure how iron is bound to red blood cells. It is also a more accurate measure of protein status than albumin. Cholesterol levels normally range between 160 and 200 milligrams per deciliter. Values are typically low with malabsorption, liver disease, pernicious anemia, end-stage cancer, or sepsis. A cholesterol level below 160 milligrams per deciliter has been identified as a possible indicator of malnutrition. And finally, total lymphocyte count will also be lower with malnutrition. Classic nursing diagnosis: imbalanced nutrition, less than body requirements, related to inability to ingest or digest food or absorb nutrients because of biological, physiological, or economic factors. Other diagnoses include risk for impaired skin integrity related to alterations in nutritional state, risk for infection related to malnutrition, risk for disturbed body image related to biophysical changes from weight loss. Interventions. It's always best for patients to get nutrients through the most normal route, eating and drinking. It's safer, cheaper, and more enjoyable. Patients with difficulty eating and drinking can be helped the following ways. Provide favorite foods. Put in hearing aids, glasses, and teeth. Provide calm, quiet environment with lots of time to eat. And remove gross things from the room. Treat pain. Move to a comfortable position. Ensure that the patient is well rested and oxygenated. Some patients might benefit from nutritional supplements such as Ensure or Boost. Oftentimes, patients will eat better if food is brought in by family members. Drug therapy may be used for some patients to stimulate appetite. For example, megestrol acetate, Megace, may be used to increase appetite in those who have cancer or AIDS, in which appetite is diminished and protein breakdown is common. Multivitamins, zinc, and iron preparations are often prescribed to treat or prevent anemia. If the patient cannot get adequate nutrition through the oral route, the next step is total enteral nutrition, and the next step after that would be parenteral nutrition. Total enteral nutrition is required when patients are unable to meet their nutritional energy requirements through the usual oral intake. Patients might have an inability to eat, absorb nutrients through the stomach, or require more calories than they're able to consume. Examples of conditions that can cause permanent swallowing problems are strokes and severe head trauma, advanced multiple sclerosis. Patients with a gastrectomy require nutrition delivered directly into the duodenum or jejunum. Enteral nutrition might be contraindicated for patients with peritonitis, pancreatitis, intractable vomiting or diarrhea, and paralytic ileus. The dietitian will do an assessment of the patient to determine the best formula to use. Formulas exist for diabetics and for those with poor kidney function. Enteral nutrition can be delivered through a tube down the nose to the stomach, duodenum, or jejunum. These tubes should be small, about 18 to 12 French. A better method for the long term is to deliver it through a stoma, a hole, through the stomach, duodenum, and jejunum. There are fewer complications, and there's more comfort when delivered through the enterostomal route. The most common types of enterostomal tubes are gastrostomies and jejunostomies. The surgeon directly accesses the GI tract using various surgical endoscopic and laparoscopic techniques. A gastrostomy is a stoma created from the abdominal wall into the stomach, through which a short feeding tube is inserted by the surgeon. It may require a small abdominal incision or may be placed endoscopically. This tube is called a percutaneous endoscopic gastrostomy, or PEG, P-E-G. The PEG does not require general anesthesia for placement and is more secure and more durable than traditional gastrostomies. Jejunostomies are used less often than gastrostomies. A jejunostomy is used for long-term feeding when it's desirable to bypass the stomach, such as with a gastrectomy or upper GI obstruction. The main complication of enteral feedings are clogged tubes and dislocated tubes. To prevent the clogged tube, flush the tube with 20 to 30 mLs of water, or the amount prescribed by the healthcare provider or nutritionist, at least every 4 hours during your continuous tube feeding. Before and after each intermittent tube feeding, before and after drug administration, and use warm water. After checking the residual volume. If the tube becomes clogged, use 30 mLs of water for flushing, applying gentle pressure with a 50 ml piston syringe. Whenever possible, use liquid medications instead of crushed tablets. If you must crush meds, dissolve well with warm water and don't mix with the feeding. Confirming placement. Always confirm feeding tube placement by X-ray before starting the first feeding and whenever there is suspicion of displacement. Also check by one of the following methods each time a bolus is given. Testing aspirated contents for pH, the most practical and easiest method. Bilirubin, trypsin, or pepsin. Assessing for carbon dioxide using capnometry. Testing pH of gastric contents. The pH of gastric fluid is 0 to 4, while a pH of greater than 6 would be in the lungs. The traditional osculatory method for checking tube placement is not reliable, especially for patients with small bore tubes. In this method, the nurse instills 20 to 30 mLs of air into the tube, insufflation, while listening over the epigastric area of the stomach with a stethoscope. The resulting whooshing sound does not guarantee correct tube placement. If enteral tubes are misplaced or become dislodged, the patient is likely to aspirate. Aspiration pneumonia is a common, life-threatening complication associated with TEN, especially for older adults. Observe for increasing temperature and pulse. Auscultate lungs every 4 to 8 hours to check for diminished breath sounds, and especially in the lower lobes. Patients may become short of breath and report chest discomfort. A chest X-ray confirms this diagnosis and a treatment with antibiotics is started. Abdominal distension, nausea, and vomiting during tube feeding are often caused by overfeeding. To prevent overfeeding, check gastric residual volumes every 4 to 6 hours. The American Society of Parenteral and Enteral Nutrition, ASPEN, recommends holding a feeding if the gastric residual volumes are greater than 200 mLs. Complications of enteral feeding. Fluid and electrolyte complications include hypernatremia and dehydration. Excessive diarrhea may develop when hyperosmolar enteral preparations are delivered quickly. This situation can also lead to dehydration through excessive water loss. Most of these formulas can be started full strength, but slowly at 15 to 20 mLs per hour. The rate is gradually increased as the patient tolerates and as the expected nutritional outcome is achieved. If diarrhea continues, especially if it has a very foul odor, the patient should be evaluated for Clostridium difficile or other infectious organisms. Contamination can occur because of repeated and often faulty handling of the feeding solution and system. Wear clean gloves when changing systems and adding product. Sterile gloves may help preventing infection in the critically ill or immunocompromised patients. Multiple liquid medications can also cause diarrhea due to their high osmolarity. When a patient cannot effectively use the GI tract for nutrition, either partial or total parenteral nutrition therapy may maintain or improve his or her nutritional status. This form of IV therapy differs from standard IV therapy in that any or all nutrients, carbohydrates, proteins, fats, vitamins, minerals, and trace elements can be given. 1 liter of IV fluid containing 5% dextrose, which is often used as a standard therapy, provides only 170 kcals. A hospitalized patient typically receives 3 to 4 liters per day, for a total of number of calories ranging between 5 and 700 calories. This calorie intake is not sufficient when the patient requires IV therapy for prolonged periods and cannot eat an adequate diet or has increased caloric needs for tissue repair and building. Parenteral nutrition is usually given through a cannula or catheter in a large distal vein of the arm or through a peripherally inserted central catheter, a PICC line. Total parenteral nutrition must be delivered through a pump and through a filter. Some parenteral nutrition products are a mixture of lipids, 10 to 20% fat emulsion, and amino acids, dextrose, usually 10%. This mixture of 3 types of nutrients is referred to as a 3-in-1 or 3-to-1 total nutrient admixture or triple mix. Quality and safety measures for TPN administration. You want to check each bag of TPN along with another nurse for accuracy by comparing it with the physician or pharmacist's prescription. Monitor the IV pump for accuracy in delivering the prescribed hourly rate. If the total parenteral nutrition solution, the TPN, is temporarily unavailable, you must give 10% dextrose water, DW, or 20% DW until the TPN solution can be obtained. If the TPN administration is not on time, if they're behind, do not attempt to catch up by increasing the rate. Monitor the patient's weight daily or according to the facility protocol. Monitor serum electrolytes and glucose daily or per facility protocol as well. Some facilities require finger-stick blood sugars every 4 hours, especially if the patient is receiving insulin. Urine testing for ketones may also be requested. Monitor and carefully record the patient's intake and output. Assess the patient's venous access site for signs of infection or infiltration. Change the dressing around the IV site every 48 to 72 hours or per facility protocol. Obesity refers to an excess amount of body fat when compared with lean body mass. The normal amount of body fat in men is between 15 and 20% of body weight. For women, the normal is 18 to 32%. An obese person weighs at least 20% above the upper limit of the normal range for their ideal body weight. For example, a young lady with a height of 5 foot 2 inches should have an ideal body weight of about 120 pounds. So if she weighed 144 pounds, she'd be considered obese. If she weighed 240 pounds, she'd be considered morbidly obese. Morbid obesity refers to a weight that has severe negative effects on health, usually more than 100% above ideal body weight, which is taking ideal body weight and doubling it. More than 1/3 of the U.S. population are considered to be obese, and another third are overweight, and about 10% or more of adults are morbidly obese. This problem is the second leading cause of preventable deaths in the United States, second only to smoking, and has really become a national crisis. However, the debate is open as to what should really constitute normal weight range, taking into account those with lots of muscle and bone. Some would argue that activity and fitness level play a more prominent aspect in health prevention than size and weight. The following conditions have been linked to obesity: type 2 diabetes mellitus, hypertension, hyperlipidemia, which is increased serum lipids, coronary artery disease, or CAD, stroke, peripheral artery disease, PAD, metabolic syndrome, obstructive sleep apnea, depression and other mental health and behavioral health problems, urinary incontinence, cholelithiasis, which is gallstones, gout, chronic back pain, early osteoarthritis, and decreased wound healing. Weight is lost only when the energy used is greater than intake. Weight loss may be accomplished by nutritional modification or without the aid of drugs in combination with a regular exercise program. Patients who may be candidates for surgical treatment include those who have repeated failure of non-surgical interventions, a BMI equal to or greater than 40%, and a weight of more than 100% above ideal body weight. The ideal diet plan and a weight loss of 1 to 2 pounds per week. A reduction of 500 fewer calories per day can achieve this effect. A reduction in 10% in body weight can improve health greatly and reduce the likelihood of developing the above listed complications. Very low calorie diets, 200 to 800 calories a day, require high protein supplementation, or patients run the risk of burning protein for energy instead of fat, up to 70 grams per day of protein, in fact. Nutritionally balanced diets generally provide about 1,200 calories per day, with a conventional distribution of carbohydrate, protein, and fat. For example, Weight Watchers is an organization that provides education about nutritionally balanced diets based on a point system and weekly group support meetings. Unbalanced low-energy diets, such as the low-carbohydrate diet, for example, Atkins or South Beach, restrict one or more nutrients. Protein and vegetables are encouraged, but certain carbohydrates and high-fat foods are not. Although they remain controversial in the medical community, these diets are extremely popular. Scientific outcome data have been conflicting. Ideally, patients will maintain a lifetime of increased physical activity with the assistance of a multidisciplinary team. It's best to start a sedentary patient walking for 30 minutes per day, 5 days a week, and gradually increase the duration and intensity. Studies have been and continue to be conducted on the benefits of activity and disease prevention. Weight loss medications work by either suppressing appetite or suppressing nutrient absorption. Anorectic drugs suppress appetite, which reduces food intake and over time may result in weight loss. Meridia is an example of a drug that suppresses serotonin and norepinephrine. The patient has the feeling of fullness and has a rise in metabolic rate. Orlistat, Xenical or Ali, inhibits lipase, the enzyme that breaks down fat. Because fats are only partially digested and absorbed, calorie intake is decreased. Most patients taking this drug have GI symptoms that include loose stools, abdominal cramps, and nausea. Therefore, it should be used with caution and limited to adults between 18 and 75 years of age. Treatment is not usually extended beyond 12 months. Morbidly obese people who do not respond to the traditional interventions may be considered for a major surgical procedure aimed at producing permanent weight loss. Patients with a body mass index, BMI, of 40 or greater, or a BMI of 35 or greater with additional risk factors are considered for surgery. Bariatrics is a branch of medicine that manages obesity and its related diseases. Surgery for obesity treatment includes restrictive measures or restrictive malabsorption measures. Every year, more than 100,000 people in the United States have bariatric procedures. Fortunately, these procedures are generally done in a minimally invasive fashion, laparoscopically, which speeds the recovery process. Preoperative care is similar to that for any patient undergoing abdominal surgery or laparoscopy. But obese patients can carry the extra cardiopulmonary risk factors due to general state of poor conditioning. Some surgeons require limited weight loss before bariatric surgery to decrease the chance of complications. Patients also have a thorough psychological assessment and testing to detect depression, substance abuse, or other mental health behavioral issues that could interfere with their success after surgery. Patients who are not alert and oriented or do not have sufficient strength and mobility are not considered for bariatric surgery. Nurses are instrumental in preparing patients for what's to come during the recovery period. Currently, the laparoscopic adjustable banded gastroplasty, and LABG is common. LAGB is considered restrictive surgery. Restrictive surgery involves separating the stomach into a small pouch to hold less food and thereby making it so the patient can only eat very small portions. This is like the old stomach stapling of the past. In the LABG procedure, the surgeon places an adjustable, usually inflatable, band to create a small pouch at the top of the stomach. The pouch is about the size of an egg, and once 30 mL of food fills this pouch, the patient no longer has a desire to eat. The band can be adjusted through injection of saline into a port. Restrictive surgeries are the easiest to perform and can be reversed. However, weight lost is often regained after a period of time. The most common malabsorption surgery performed in the United States is the Roux-en-Y gastric bypass, or RGB, which is often done as a robotic surgical procedure, once again in a minimally invasive fashion. With this procedure, the patient will lose more weight and has a much better chance of keeping it off, but the procedure carries more risk than the lap banding. In the Roux-en-Y procedure, a pouch is made by separating the top part of the stomach from the rest of the stomach. The jejunum is cut and brought all the way to the pouch. So now the food that fills the pouch runs directly into the jejunum and bypasses the duodenal absorption. The rest of the stomach still receives bile and juice from the biliary organs, and that juice will run down into the jejunum at the Y juncture. Patients have a quick recovery time with the minimally invasive surgery, staying maybe 1 or 2 days in the hospital. The priority for immediate care of postoperative bariatric patients is airway management due to a thick and short neck. All patients experience some degree of pain, but is usually less severe when laparoscopic approach is used. Patients may use patient-controlled analgesia with morphine for up to the first 24 hours, and then will use oral opioid analgesic agents as prescribed after the PCA is discontinued. Special bariatric equipment and accommodations, including the extra-wide bed and additional personnel for moving the patient, are often used, and they're needed for both the surgical suite and the post-op care units. Some patients have an NG tube, nasogastric tube, in place for decompression, especially after open surgical procedures. Never reposition the tube, because its movement can disrupt the suture line. The NG tube is removed on the second day if the patient is passing gas, or flatus. Clear liquids are introduced slowly if the patient can tolerate water, and a 1-ounce cup are often used for servings. Pureed foods, juice, and soups thinned with broth, water, or milk are added to the diet 24 to 48 hours after clear liquids are tolerated. Typically, the patient can increase the volume to 1 ounce over 5 minutes or until satisfied. But the diet is limited to liquids or pureed foods for the first 6 weeks. The patient then progresses to regular food with an emphasis on nutrient-rich foods. Nausea, vomiting, or discomfort occur if too much liquid is ingested. Anastomotic leaks are the most common and serious complication and can cause death after gastric bypass surgery. Monitor for manifestations of this life-threatening problem, including increased back, shoulder, and abdominal pain, restlessness, and unexplained tachycardia and oliguria, scant urine. Report any of these findings to the surgeon immediately. In addition to the post-operative complications typically associated with abdominal and laparoscopic surgeries, bariatric patients have special needs and risks. Implement these measures to prevent complications. Apply an abdominal binder to prevent wound dehiscence. Place the patient in a semi-Fowler's position or use the bi-level or continuous positive airway pressure, BiPAP, or CPAP to at night to improve breathing and decrease the risk for sleep apnea. Monitor oxygen saturation. Provide oxygen at 2 liters per minute as prescribed. Apply sequential compression stockings and administer prophylactic anticoagulants, usually heparin therapy, as needed to prevent thrombolytic complications, including pulmonary embolism, a PE. Observe skin areas and folds for redness, excoriation, or breakdown and treat these problems early. Use absorbent padding between folds to prevent pressure areas and skin breakdown. Make sure that tubes and catheters are not causing pressure as well. Remove urinary catheters within 24 hours after surgery if possible to prevent urinary tract infections. Ambulate the patient as soon as possible to prevent post-op complications such as PE. Measure and record abdominal girth daily. In collaboration with a nutritionist, provide 6 small feedings and plenty of fluids to prevent dehydration. Observe for signs and symptoms of dumping syndrome caused by food entering the small intestine instead of the stomach after a gastric bypass, such as tachycardia, nausea, diarrhea, and abdominal cramping. Inflammatory bowel disorders affect the small intestine, large intestine, colon, or both. Continued digestion of food and absorption of nutrients occur primarily in the small intestine or bowel to meet the body's need for energy. Water is absorbed in the large intestine to help maintain a fluid balance and to promote the passage of waste products. When the intestinal tract and its nearby structures become inflamed, digestion and nutrition may be inadequate to meet the patient's needs. Ulcerative colitis, UC, creates widespread inflammation of mainly the rectum and sigmoid colon, but can extend to the entire colon. Ulcerative colitis is a disease that is associated with periodic remissions and exacerbations or flare-ups. In the mild disease, the intestinal mucosa is edematous and reddened. In more severe inflammation, the lining can bleed and small erosions or ulcers occur. Abscesses can form in these ulcerative areas and result in tissue necrosis or cell death. Continued edema and mucosal thickening can lead to narrowed colon and possibly a partial bowel obstruction. The patient's stool typically contains blood and mucus. Patients report tenesmus, an unpleasant and urgent sensation of needing to defecate, and lower abdominal colicky pain relieved with defecation. Malaise, anorexia, and weight loss are common. Ulcerative colitis and Crohn's make up the diagnosis of inflammatory bowel disease. The cause is actually unknown, but like other autoimmune conditions, it's thought to be caused by an interplay of genetics and environmental factors. The disease occurs at the highest rates in Northern Europe and North America. It affects about 2 million people in the United States. A person's risk for the disease is 10 times greater if she or he has a first-degree relative, a parent, sibling, or child, with the disease. Peak age is about 20 and 40 years of age, and again at 55 to 65. People who do not smoke and those who quit smoking are at a higher risk for having ulcerative colitis than people who smoke. The reason for this relationship is not known, but nicotine has a positive influence on the smooth muscle of the colon, and ulcerative colitis is 4 to 5 times more common among people of European, Jewish, or Sephardic origin. As a result of chronic blood loss, hematocrit and hemoglobin levels may be low, which indicates anemia and a chronic disease state. An increased white cell count, platelet count, C-reactive protein, or erythrocyte sedimentation rate levels is consistent with inflammatory disease. Blood levels of sodium, potassium, and chloride may be low as a result of frequent diarrheal stools and malabsorption through the diseased bowel. Hypoalbuminemia, decreased serum albumin is found in patients with extensive disease from losing protein in the stool. A colonoscopy is the most definitive test for diagnosing ulcerative colitis. In some cases, a computed tomography, or a CT scan, may be done to confirm the disease or its complications. Barium enemas with air contrast can show differences in the UC in ulcerative colitis and Crohn's disease, and identify complications, mucosal patterns, and the distribution and depth of the disease involvement. In early disease, barium enemas may show incomplete filling as a result of inflammation and fine ulcerations along the bowel contour, which appear deeper in more advanced disease. Common drug therapy for ulcerative colitis includes aminosalicylates, glucosteroids, immunomodulators, and antidiarrheal drugs. The aminosalicylates work by decreasing inflammation right in the area of the intestinal lining. Like aspirin, the effect comes from the prostaglandin inhibition. Drugs in this category include azolfidine and mesalamine. Glucocorticoids such as prednisone, 40 to 65 milligrams daily, is often given orally. Once clinical improvement occurs, the corticosteroids are tapered because the adverse effects that are common occur with long-term steroid therapy, such as hyperglycemia, osteoporosis, peptic ulcer disease, and an increased risk for infection. For patients with rectal symptoms, topical steroids in the form of small retention enemas may be prescribed. Hydrocortisone rectal foam, cortifoam, is prescribed as 1 to 2 times daily for 2 to 3 weeks, and then every other day. Hydrocortisone enemas, quart enema, are given at bedtime for 21 days, tapered, and discontinued. Immunomodulators are drugs that alter a person's immune response. They are not thought to be effective in the treatment of ulcerative colitis. However, in combination with steroids, they may offer a synergistic effect to get a quicker response, and thereby decreasing the amount of steroids needed. For example, cyclosporine used in a severely ill patient might avoid an emergent colectomy. Immunosuppressants used with ulcerative colitis and Crohn's disease include azathioprine, mercaptopurine, cyclosporin, methotrexate, infliximab, and adalimumab. There we go. To provide symptomatic management of diarrhea, antidiarrheal drugs may also be prescribed. These drugs are given very cautiously, however, because they can cause colon dilation and toxic megacolon. Common antidiarrheal drugs include diphenoxylate hydrochloride and atropine sulfate, or Lomotil. as well as loperamide or Imodium. Patients with severe symptoms are kept NPO to ensure bowel rest. The medical provider may prescribe total parenteral nutrition for severely ill and malnourished patients. Often, lactose-containing foods are poorly tolerated and should be reduced or eliminated. Warn the patient that caffeinated beverages, pepper, alcohol, and smoking are common GI stimulants that could cause discomfort. Smoking and other forms of nicotine have been shown to help and heal ulcerative colitis, but this approach is actually not recommended. Some patients with ulcerative colitis require a colectomy, a surgical colon removal, and ileostomy. Indications for surgery include hemorrhage, failure of the conventional treatments, and colon cancer. An ileostomy is a procedure in which a loop of the ileum is placed through the abdominal wall, a stoma, for drainage of fecal material into a pouching system worn on the abdomen. The pouching system consists of a solid skin barrier or wafer to protect the skin and fecal collection device, the pouch. Total colectomy with a permanent ileostomy has traditionally been the standard surgical procedure for patients undergoing a colectomy and involves the removal of colon, rectum, and anus with surgical closure of the anus. The surgeon brings the end of the ileum out through the abdominal wall and forms a stoma or ostomy. The stoma is usually placed in the right lower quadrant of the abdomen below the belt line. It should not be prolapsed or retracted into the abdominal wall. The stoma should be pinkish to cherry red because it should be receiving an adequate blood supply. If it looks pale, bluish, or dark, report these findings immediately to the healthcare provider. With a permanent ileostomy, initially after surgery, the output is a loose, dark green liquid that may contain some blood. Over time, a process called ileostomy adaptation occurs. The small intestine begins to form some of the functions that had previously been done by the colon, including the absorption of increased amounts of sodium and water. Stool volume decreases and becomes thicker, paste-like, and turns yellow-green or yellow-brown. The ostomy drains frequently and stool is irritating. The patient must wear a pouch system at all times. The stool from the small intestine contains many enzymes and bile salts which can quickly irritate and injure the skin. Skin care around the stoma is a priority. Ileoanal anastomosis. This procedure involves the surgical removal of the colon and the rectum and sutures the ileum into the anal canal or small cuff of the rectum. A temporary loop ileostomy is created to allow healing of the internal pouch and all anastomosis sites. After 3 to 4 months, the patient returns to have the loop ileostomy closed. The creation of an ileoanal reservoir, also known as a J-pouch, has become popular for many patients with ulcerative colitis, especially young adults, because it spares the rectal sphincter and eliminates the need for an ostomy. The surgeon removes the colon and sutures the ileum into the rectal stump to form a reservoir. Crohn's disease is an inflammatory disease of the small intestine, mostly, the colon, or both. It can affect the GI tract from the mouth to the anus, but most commonly affects the terminal ileum. Crohn's disease is a slowly progressive, unpredictable, and recurrent disease with involvement of multiple regions of the intestine, with normal sections in between, called skip lesions on X-rays. Unlike ulcerative colitis, Crohn's disease presents as a transmural, across all layers, inflammation that causes a thickened bowel wall. Strictures and deep ulcerations, cobblestone appearance, also occur, which predispose the patient to developing bowel fistulas. The result is severe diarrhea, malabsorption of nutrients. Anemia is common, usually from an iron deficiency or other malabsorption issues. The clinical presentation of Crohn's disease can vary greatly from one person to the next. Most patients report diarrhea, abdominal pain, and low-grade fever. Fever is common with fistulas, abscesses, and severe inflammation. If the disease occurs in only the ileum, diarrhea occurs 5 or 6 times per day, often with a soft, loose stool. Steatorrhea, fatty diarrheal stools, is common. Rarely, stools may contain bright red blood. Abdominal pain from the inflammatory process is usually constant and located in the right lower quadrant. The patient may also have pain around the umbilicus before and after bowel movements. Most patients with Crohn's disease have weight loss.